always like to thank Beaver County Behavioral Health because they give us the support and the opportunity to be able to do this and allow all you guys to come and get some training credits for free. And that's a really good thing that they're able to offer. So we're grateful to BCBH. That's where we are. So I wanted to start by sharing with you a little story. It's a little follow-up story to those of you who were on our last session. So in our last session, I shared that I had a former patient who I had not seen in a number of years, but I had continued to work with his family, and the young man had completed suicide. That was the Saturday before Thanksgiving. And I've been continuing to work with the family, and it's been, if any of you have had scenarios with clients where you have lost someone like that, or lost a client to overdose, those types of things, or just lost a client for other reasons that they have passed on, it can throw you for a loop. It definitely threw me for a loop. And I remember I went to the memorial service, and at the memorial service, I thought to myself, maybe I shouldn't be doing this anymore. Maybe I'm spent. And then a number of things happened that kind of put that back into perspective for me. And I always think those things, just appreciate when those things happen so much. But one of the things that happened was the memorial service was on a Monday, and then we met on Wednesday. And the following Friday, I had a patient on my schedule. He's scheduled with our secretary. And this is a patient who last year in the spring of 2019, I actually had hospitalized. I had to go to his house with the police to do a welfare check, and was able to convince him to go to the hospital. And we took him to the hospital, and he was admitted, and he stayed there for a couple of weeks, and he went to the LTSR, and then he did not come back to see me. And so many of you know, when you have to hospitalize someone, a lot of times they do get angry. Even though he did make the decision, it wasn't an involuntary, he did not come back to see me. And that did not surprise me, but was sad. So now, fast forward a year and a half later, and he calls and makes an appointment, and I'm kind of thinking, well, what's this session going to be like? But he does want to get back into therapy, and he's doing really well. But he also wanted to share with me that if I had not intervened that day, he would have killed himself. He was prepared. He had everything ready. And that was going to happen, and that he's very grateful about the intervention. So I think that was kind of just full circle. And I think those stories are important for us to recognize in our professional work, and to share sometimes that, our work is hard and not all of it goes the way we want it to. But sometimes really beautiful things happen from our work. Oftentimes really beautiful things happen. And now that gentleman did decide to come back and get back into therapy with me. Had he not, over the last year and a half, he's been very grateful that sorry, my cat is being a little crazy. He has, over the last year and a half, been very grateful, but he hadn't expressed that to me. And so sometimes we don't know the way we touch our clients. Sometimes we're lucky enough that they share them with us. So I wanted to just give that story. It goes a little bit full circle about how, and I think the timing of it, that's what I always find really interesting, is the timing of how that gentleman came back at that time when it was really helpful for me to be able to continue to do the work. So I hope you have experiences like that, that if you have something that happens that's really tough and difficult and makes you even question the work that we do, then I hope you have one of those redeeming moments that comes, and I hope it comes quickly, because they're really, really helpful. And I was mentioning to Jen this morning, and we'll talk about it some more, that right now, like, many of my clients are in, I would say, crisis. They're in crisis mode. The continuation of the COVID and the lack of regular supports that they're used to getting is plucking away at everybody's tank of emotional stability, I would say. So I think we're just seeing more and more of that, and that's not going to stop anytime soon. I don't think we're gonna continue to have to deal with that. And that's I went to the AT&T store the other day to get my son a new iPhone for Christmas. And the guy was like, "What do you do for a living?" He's like, "Are you a first responder? Are you a teacher?" He rattled off all these things because AT&T is giving discounts to all these different professions. And I was like, this close, I'm this close. And I was like, "I'm a counselor." We didn't quite make the list, but we should because we're doing hard work. We're doing really important work. So with that, I am going to share my screen, and we're going to go ahead and get started talking about medications and all those kind of wonderful things. Hang on here for me. There we go. Now we got it finally. Okay. I need to make this small for myself. Okay, there we go. So today we're talking about choice and voice, and we're talking about helping clients with co-occurring disorders and how to manage their medications. So as you know, I'd like to start by just taking an opportunity to offer everyone that we all just need to breathe and keep breathing. And so I don't know, this was the picture that inspired me today to just smile and, you know, just breathe, you know, just keep breathing. So take that moment. Sometimes the things we talk about in these trainings can be a little touchy and then sometimes they're a little triggering to us because we're sensitive, compassionate people. So just prepare yourselves and just breathe and know that we're just going to spend time together today and get done what we have to get done. A moment of reflection to just remind us again, and I know I do this every time, and I thought to myself as I was putting together the slides today, is this getting too repetitive? And it might be getting repetitive, but repetition sometimes is really, really important. And so I want to remind us all that we are living in a traumatic time period, and it's unprecedented. And it's not traumatic like I was watching a movie yesterday called Rust Creek. It's on Netflix. If you get a chance, it was pretty good. But this young woman, college student, was traveling and she got stuck and attacked by these crazy people, and she was kidnapped and and she was alone in the woods. And I was thinking to myself, oh my gosh, I would be terrified. And so what we're going through now isn't that kind of terrifying, but at the same time, it's still very unnerving. So Jessica saw that movie. She said, yeah, it was pretty good. And remember, even though we're in this crazy kind of time, that you and we are responsible for a lot of things. We're responsible to take care of ourselves, right? If we don't take care of ourselves, we can't continue to do the work that we do. And we're responsible to take care of our families, our coworkers, certainly our clients. So we have a lot of responsibility. And so let me take another moment today to just tell you, in case no one else tells you today, that the work that you're doing is really, really appreciated very much. So keep it up. Reminder just about what we're dealing with in the pandemic is a lot of dealing with grief. You know, our lives, as we approach Christmas, for example, Christmas is not going to look this year like it did last year. Thanksgiving didn't look like it did last year. Hanukkah, all these things that we had some routine and ritual to look very different. And that's some grief. And so we see these different stages of denial and some anger, depression, and all sorts of things. And it's very chaotic. I always like to use this graph because unlike the Kubler-Ross, which makes it look, I know it's not how they want to portray it, but it makes it look like almost easy, like routine, like, oh, it's just a little up and down, when really grief is oftentimes more like this, much more chaotic. But think about this when you think about where people are that you're dealing with. Remember that nothing's normal right now. There's lots of uncertainty. I think everyone's really looking forward to the new year, 2021, like put 2020 behind us, but we're moving into 2021 in a weird way. So it's still going to be different for sure. And people are concerned about meeting their needs and being able to have a good holiday. Uh, so this is difficult for everyone, but particularly many of the folks that we're dealing with who have histories of mental health issues or substance abuse issues or trauma. So I don't know if any of you can see me, or you probably just see my screen, but my cat just literally leaped across in front of me chasing something. So these are the joys of working from home, right? So since we're talking about medications today, I always try to find something educational to help us kind of frame what we're doing, what's happening in the pandemic. And so this is one that struck me today. Now keep in mind that this data here is from way back in February. So this would look even bigger now, but these are mental health prescription spikes amid pandemic fears. And so the increases we've seen are in anti-anxiety medications, antidepressants, and medications to help with sleep. So this was way back in February that we were already seeing these spikes. That was barely at the beginning of what was going on. And so the spikes have continued even more. So a lot of what this says to me is that, you know, we deal with patients often who are already on medications. Now, these are patients who probably weren't on medications, but now are. And so that's changing the dynamics of what we're dealing with. So we want to just keep that in mind as we can't forget that we're in the pandemic as we look at what our topic is today in dealing with medications and helping our clients with that. This one I thought was interesting too. This is from May. This is across 12 different countries. And it's entitled Party Drugs Lose Out Because of COVID-19. So the drugs that we've seen an increase in marijuana, alcohol, and benzodiazepines. And the drugs that we've seen a decrease in across the world, cocaine and MDMA. So what that tells me is, marijuana, alcohol, benzodiazepines, all depressants, all things that in theory help to calm the body and the central nervous system, and then help kind of escapism. They don't make us crazy and fun necessarily, although sometimes it depends what you got, I guess. But they're things that kind of help to calm people. And so those are the drugs, the party drugs, that are being attended to more frequently. I don't think that surprises any of us here. And again, this is for like regular earth people. That we're not talking about substance people with substance use disorder here, because that can look a little bit different based on brain chemistry. So we're going to talk about co-occurring disorders today. We're going to talk about people who are dealing with mental health issues and substance use issues, and we know from the work we've done so far and the experiences that you guys have had that it's important that we put both of those things together when we're trying to help patients get better. So to start off, I want to make sure everyone had the number here for poison control. So poison control is, Mr. Yaakov, for those of you who remember him from way back when. They still use him, but I don't know, I guess he impacted me more as a kid than he does now. But poison control is a very important number because you can call it about anything. So you can call it about prescription drugs, you can call it about illicit drugs, you can call it about things that people may ingest that are not drugs at all, like, dish soap or something, Tide Pods, things like that. You can also call it if you have concerns about something that your animal has ingested. So years ago, we had a cat. Funny story, when we got the cat, it was a very long-haired cat, and we were told that she was a female, and so her name was Katie. And about 9 years later, Katie became sick. We took her to the vet. My husband at the time had called me at work and said that Katie was diabetic, and so we had to start giving her these shots twice a day. And he said, also, Katie's a boy. So the kids who were little at the time changed Katie's name to Katie Bob. But one time I overdosed Katie on his insulin because my husband always gave the insulin because I don't like needles. I don't like weird things like that. But one night he was coming home late and I thought, you know what, your animals, they're like your kids. You just got to do things that you don't want to do, right? But I couldn't remember the dose. So I thought I gave him less of a dose than he was supposed to get. And then I figured when my husband got home, he could give him the rest of the dose. When he gets home, I'm upstairs putting the kids to bed. He gives the cat his shot, not knowing that I already did. He comes upstairs and tells me that he did. And I said, well, I did. And I told him what I gave him. And I had given him too much to begin with, plus the dose he gave him. So anyway, call poison control. And we had to feed the cat tuna all night. And that's kind of how he turned out to be fine. So that we were lucky. But you can call poison control even with things with animals. So it's just a really important number, and I encourage you to have it around your home. Get yourself a Mr. Yuck sticker. You can order them online, put them in your office because they can be helpful. Yeah, if someone ingests bleach, for example. So let's talk about a couple definitions when we're dealing with medications. So, and some of this at the beginning when we talk about the medications themselves, I'm going to try to run through quickly because at the end, what I really want us to spend time on is how to motivate your clients, educate your clients, and things like that. But some of this background is important for us to know because this is education we can help our clients with and teach our clients as well. So psychotropic comes from two things. The Greek word for psycho, which is the mind, and then trop, which means a turning. So psychotropic is about being capable of turning the mind or changing something in the brain. So some other definitions we want to keep in mind is the Food and Drug Administration. They are responsible for public health. They're responsible for all sorts of things like safety, efficiency, security of medications, veterinary drugs that they're used at the veterinarian, biological products, including like various diet supplements and things like that, as well as the food supply, cosmetics, and any products that emit radiation. So they do a lot, right? One thing that they don't cover for the most part are herbal products, herbal supplements, and things like that. And so we're going to talk about that a little bit later because that's important to know. Sometimes drugs have an off-label use, or a doctor may talk to you about using a drug off-label, or a patient may come to you and say that they're taking a certain medication and you're thinking, well, I've never heard of that medication for this particular diagnosis. So doctors are able to use medications off-label, which means that they're using it for something that it wasn't necessarily studied for, but they found that it works. Some insurance companies don't pay for off-label medications, or they might require some sort of prior authorization. Black box warnings come on medications, and this is like the ultimate warning by the FDA that this medication may have some sort of life-threatening risk. So for example, acne medication, there's a black box warning connected to suicidality. So it's called the black box warning because they really want you to take a look at it and know that this, even though it may not happen often, if it does happen, it's really bad. So that's why they have the black box warning. We're going to talk today about medications and neurotransmitters. These are the messengers in the brain that communicate between brain cells. So they're pretty important. We're going to talk about serotonin, which is one of the neurotransmitters that is good for us, let's say. We're going to talk about GABA, which is another neurotransmitter that blocks impulses. So people who have low levels of GABA may have difficulty with anxiety or mood disorders, things like epilepsy, or they may have a lower tolerance to pain or more chronic pain. Oh, this one's kind of hard to see, but I did think it was important that when we think about terms of medication, these are the most common prescription medications in our country right now. Medications for pain, medications for cholesterol, blood pressure, hypothyroidism, GERD, which is well, it's basically like heartburn, a reflux disease. I know that's the end. Infections and diabetes, mostly type 2 diabetes. So when you look at these drugs, the types of things that we give people medications for, they're not usually, the psychotropic medications are not as common as the other, and that's just something to keep in perspective. Oh, look at that! Do you see? I forgot that I made the slide do something pretty. So first, briefly, let's talk about SSRIs, which are selective serotonin reuptake inhibitors. So these are antidepressants that are most commonly prescribed. They tend to have minimal side effects. And what they do is they can help depression by increasing the levels of serotonin in the brain. So for any number of reasons, the brain may produce less serotonin, or and so these medications help release some more of that. They're called selective because they seem to primarily affect serotonin and not the other transmitters, neurotransmitters. So that's the selective part, is they just really focus on the serotonin. One of the things I often tell clients about SSRIs or antidepressants in general is that it's not going to make them happy. Sometimes I do have a patient who calls them her happy pills. They're not going to make you happy, but what they can do is kind of even out the chemicals in your brain so that the things you do have to deal with maybe become a little easier to deal with. And so that's kind of how I explain it to clients. Here's a picture of what it looks like when this is particularly with Prozac, and you can see the serotonin is there in the middle, and the slide on the left, there's a deficit. Most of it's up in the top and not in the middle between the synapses there. And over on the right with the Prozac, it kind of opens up those little receptors, so it allows more serotonin to be released into that part of the brain that we can experience it and feel it. And then that's kind of how it works. Things to remember about SSRIs: it can take several weeks before they start to work. Now, I will tell you that I've had many patients tell me that within even a day of starting an SSRI, they feel better. Now, I suspect that's just the halo effect, that they believe the medication is going to work. They take the medication, so suddenly they start to feel better. I think it's a great thing, because if that can stay in place for the 4 to 6 weeks until the medication actually starts working, then that's fantastic, right? But I think it's an important thing to educate clients is that the full effects of the SSRI can take up to about 6 weeks. And sometimes people want to stop taking it before they hit the 6 weeks, because after 3 weeks, they're like, it's not working. And so we really need to educate them to give it the full 6 weeks. Kind of like those antibiotics that people, you have to take it till the end. Even if you feel better, you still have to take the full 7 or 10-day dose of it. We have the same thing happen here. Sometimes people are like, it's not working. I don't feel better. Why take it? And so we need to encourage them and educate them about the time it can take. Not a ton of side effects often with SSRIs, but some people do have side effects. Most of the side effects go away within a few weeks. So some people can tolerate that and some people can't. And that's something that I think is important for us to help educate clients about. If the side effects are worse than the benefit of the medication, then it's probably not the right medication if there may be some other option. But if the side effects are workable and maybe the benefit is bigger, well, we may just have to deal with that. SSRIs are very different than, psychotropics in general are different than other medications that are used for physical issues. In this way, a lot of times, if you're allergic to an antibiotic, for example, I'm trying to remember the main one that people sometimes are allergic to. But if you're allergic to one, then you're allergic to the whole class of them. You just don't take any of them because you're allergic to that whole class. If you take an SSRI like Prozac, and let's say it doesn't seem to be effective or there's a lot of side effects, you can take a different SSRI and have an entirely different experience. So even though they're all in the same kind of class, the impact and how they impact the brain can be very different from medication to medication. So if someone tries an SSRI and it does not work, they can try a different one. If they try an SSRI and has a lot of side effects, they can try a different one and they may have a different effect. So those are some important things to help clients, educate them if they're looking at SSRIs or medications. Sometimes the medications, SSRIs, are used to treat things other than depression, including anxiety. So we'll talk about that a little bit later. But these are the main ones that we see to treat depression: Celexa, Lexapro, Prozac, which is also approved to help with some OCD, Paxil, Zoloft, Vibride. Those are kind of the basic ones that we hear about most frequently. I will say, as a therapist, this is, the Jill Perry opinion, most of these medications can easily be prescribed by your primary care physician. They're low level. PCPs usually have enough knowledge that they can make a good prescription recommendation based on this information. Some of the other medications we deal with, or if you're dealing with a client who has multiple psychotropic medications, then I always think going to a psychiatrist is most appropriate because that's their thing, right? But if you're dealing with someone, particularly like right now, with clients that are dealing with depression or anxiety connected to COVID, then talking to their PCP may be enough to give them something. There are, well, remember these side effects. I almost hate to tell patients sometimes about side effects because then sometimes they get them. And if they don't know about them, then they don't get them. But it is their right to know that there are side effects that could happen, and you want them to be alert to that. So things with SSRIs, they could have drowsiness, nausea, dry mouth, insomnia, diarrhea, nervousness, dizziness, sexual problems, headaches, blurred vision. And so those are the basics. Now, what I always tell clients, because sometimes they look at that list and they're like, holy crap, is that these don't happen often, and rarely do you get them all. but keep an eye on it. I think what I hear people complain about the most have been dry mouth, sometimes sexual problems, and headaches. Those are the ones I hear the most. Now, again, most of those side effects will go away within a couple of weeks. So if someone can tolerate them for a period of time, more than likely they're going to go away. If they don't, then that's something to definitely take a look at. There is something called a serotonin syndrome that we have to be aware of. It doesn't happen often. Mostly happens when people are combining different medications that affect serotonin. But basically what can happen is too much serotonin can accumulate in the body. And then that can cause people to be sick and to need to be hospitalized. So that's something we need to just be aware of. There are risks and benefits to using antidepressants when pregnant, breastfeeding, or when women are considering getting pregnant. So those are definitely things worth talking through with a doctor about some of those risks and the benefits. So I have a young woman who I worked with who she had lost a baby. The baby had never come home from the hospital, and she was in the hospital for 9 months, and then she died. Lots of trauma around that, right? And she had been on an antidepressant for years after that happened. And then she got pregnant again, and she wanted to go off of the antidepressant while she was pregnant. As soon as she found out she was pregnant, she's like, I just want to stop taking it. And she and I really had to talk through, was that the most appropriate thing to do? Because clearly she had a history of depression. Pregnancy, if you have a history of depression, pregnancy very well might bring it back or make it worse. And so really it was, in talking this through, the benefit of the antidepressant, and we include her doctor in this conversation as well, the benefit of staying on the antidepressant outweighed some of the risks of it. And I'm happy to say that she had a beautiful baby boy who recently turned 1 year old. He's very healthy, and the family is doing fantastic. And now she is considering getting off of the antidepressant, not because of pregnancy issues, but because she's done a lot of healing and a lot of things have changed in her life, and she's feeling like she may not need the medication anymore. So we're working on that and talking that through. But women who are pregnant, who are breastfeeding, or who are thinking about getting pregnant, definitely worth a conversation with the doctor about that. There is a black box warning on antidepressants. It's kind of an oxymoron, I think. It's kind of ironic, but that there is, for some people, they do experience an increase in suicidality when they're taking SSRIs. And so we need to really be looking out for that and listening for clues in that, and warning not only clients but their family members that this is a possibility. Again, it is rare, but when it happens, it's pretty serious, obviously. There is something also with SSRIs called a Discontinuation Syndrome. And now SSRIs, this is not like withdrawal, like people go through withdrawal from opioids or benzodiazepines, but they may have some withdrawal-like symptoms. And depending on the body, some people are pretty sensitive to it. So we encourage people not to stop SSRIs abruptly, at least not without the sign off of a doctor, because they may have things like feeling sick, nauseous, dizzy, feeling like they have the flu, and it's just not comfortable. Now, this isn't as often as frequent this isn't as severe with SSRIs as with some other medications, but it's definitely worth educating clients about so they know what to expect. Now, most of the clients I've dealt with, even who have stopped taking an SSRI just like that, they haven't weaned off, they just stopped, most of them, symptoms that they noticed, they were able to continue to work and do things. They just were a little uncomfortable for a few days. I did have some clients who said it was like the worst experience of their lives. So some of that just depends on how the different bodies react. So here's a little neurotransmitter. He's in therapy, and the therapist is saying, I think you're a little too quick on the reuptake. So just a little therapy humor, haha. Okay, so now we're going to move on to the next most frequent medications, which are SNRIs. These are serotonin and norepinephrine reuptake inhibitors. So they do the same thing as an SSRI, except they also include norepinephrine. So they're not as selective to just the serotonin. Often these things are used for depression and sometimes for anxiety disorders. Sometimes they're even used for nerve pain. And they help with these things by impacting the different transmitters, and they change the brain chemistry so that the communication in the nerve cells is kind of regulated and makes things a little easier. So these neurotransmitters of norepinephrine have a couple different roles. First of all, they relay messages in the autonomic nervous system, our fight or flight or freeze. I should have added freeze in there, but so they relay messages in that. So people who are dealing with anxiety are dealing a lot with that fight, flight, or freeze, right? That's the adrenaline that's going all the time. So norepinephrine impacts that. Norepinephrine prepares the brain to encounter and respond to stimuli from the environment. So it's all that adrenaline. It's that hyper alertness. And norepinephrine overall mediates arousal, making sure that we're alert And so it's a good thing. Like, we need it because we need to be alert. And sometimes we do need to respond quickly to what's going on in our environment. But if it's too much, then we have some excess anxiety that's pretty uncomfortable for people. This is just another diagram of what this looks like. So you have in the middle here, you don't have as much of the neurotransmitters there as you want, and so we want to try to get that flow to happen a little bit better. So the ones we hear of most often with this would be Prestige or Cymbalta, Effexor. So these are the ones that we hear most often in the SNRIs. Side effects, there are some side effects similar to SSRIs. They usually do go away within the first week. Nausea is probably the one that people talk about the most, and usually can be alleviated if they take the medicine with some food. But it depends. But people can also have dry mouth, dizziness, headache, and even excessive sweating. So that's a little bit different from the SSRIs. Tiredness, constipation, insomnia, changes in sexual functioning, loss of appetite, increased blood pressure. And then the SNRIs can have an impact on liver problems if there's liver issues already existing. SNRIs can also increase risk of bleeding. So a doctor needs to be really conscientious to make sure that the person isn't on something like Coumadin or warfarin or some sort of medication like that. SNRIs do carry the possibility of serotonin syndrome, where there's just too much serotonin that's created in the body. And there can be some harm to an unborn baby if people are taking SNRIs while they're pregnant or breastfeeding. So again, definitely worth a conversation with a doctor if a female patient is pregnant, breastfeeding, or thinking about getting pregnant. And the SNRIs are a little riskier than the SSRIs. All those initials. There's also a black box warning on SNRIs about suicidality. So that's something, again, to educate patients and their families about, and for us to keep an eye on. There's also a discontinuation syndrome with SNRIs. Again, they're not addictive substances, but people can have withdrawal-like symptoms like the flu or increased agitation and those types of things when they stop taking it, particularly if they stop taking it abruptly. SNRIs, higher risk of people feeling these types of symptoms when they stop taking it. So doctors usually will try to taper them off of this more. A doctor would more quickly tell you it's okay just to stop taking your SSRI, but for an SNRI, they probably would put together a taper down type of plan for you. Okay, so we want to talk about MAOs, MAOIs, which are not, we don't hear about these as much, but it is important that we just remember these. These were the very first antidepressants that were given. And as we go through talking about them, you're going to see why the SSRIs have become much more effective and used. But some people don't respond to them. And so there are some people that the MAOIs are definitely definitely worth it for them. But the SSRIs, the SNRIs are safer and have much fewer side effects, which is why we focus more on them. Even with MAOIs, there are specific diet restrictions that can cause really dangerous things like high blood pressure. And so it's be very conscientious. There's a lot more education that goes into working with someone with an MAOI. These medications ease depression by the same way an SRI does. They work on those neurotransmitters. They change the brain chemistry. They work with norepinephrine, serotonin, and dopamine to make things happen. Sometimes they've also used MAOIs to treat other diseases, including Parkinson's, with some pretty good success. The main medications you would hear would be Marplan, Nardil, Parnate, or MCM sometimes. And again, you probably, I would venture to say many of you, oh, Melanie says my sound keeps cutting out. I'm not sure what's happening. Let's see. Maybe it's just my voice. All right, keep me posted, Melanie, or anyone else if that seems to be happening. Excuse me. So these are the main ones you'll see. I would venture to say that many of you who are here today have never worked with a patient on an MAOI, but some of you have or will, and you just need to be aware of it because they are still prescribed. But any foods higher in tyramine can cause high blood pressure. So these are things like strong or aged cheeses, cured meats, processed meats, pickled or fermented foods, soy-based foods, soybeans, snow peas, dried or overripe fruits, and meat tenderizers. So you can see why this can be difficult for someone, because now not only do you have to take the medication, but you can't eat these foods because it can be dangerous. Side effects include very similar to the other types of side effects we've looked at with SSRIs and SNRIs. But there are some additional ones like involuntary muscle jerks, low blood pressure, sexual issues, weight gain, difficulty starting a urine flow, muscle cramps, prickling or tingling of the sensation in the skin. So you can see there's a lot more side effects, and they're more frequent than with the other medications. There is a possibility of serotonin syndrome with MAOIs, so we need to be aware of that. Definitely an issue with women who are pregnant, nursing, or considering getting pregnant. So it's definitely something that they need to talk with the doctor about. And there can be interactions, negative drug interactions between MAOIs and other antidepressants, certain pain medications, certain cold and allergy medications, and even some herbal supplements. So if you're dealing with someone who's not able to maintain a lot of diet restrictions and medication restrictions and those types of things, then this can be really difficult. So you can imagine back in the day when this was all there was, right? And of course, there is a black box warning on MAOIs around suicidality. So we need to always be on top of that. Discontinuation syndrome is more significant with MAOIs than the other medications we've talked about. Certainly things like flu-like symptoms, anxiety, agitation, insomnia, etc., but also could include things like confusion, psychosis, convulsions. Sometimes people need to wait 2 weeks or more between the use of MAOIs and other antidepressants to avoid serotonin syndrome. So a lot of times if a doctor's changing you from like one SSRI to another, or even from an SSRI to an SNRI, they just kind of do it. Like, stop taking this on Tuesday and start taking this on Wednesday. But with these MAOIs, you may need to wait till the entire medication is out of the system before putting in another serotonin focused medication. And then during those 2 weeks, even though you're not taking the medication anymore, you still need to stay on top of those food and drink restrictions, and careful of the restrictions of other drugs in your body and how it could react. So it's just a little more sensitive, this medicine. So let's talk about some anxiety medications. Medications focused on working with generalized anxiety disorder, phobias, obsessive compulsive, post-traumatic stress, panic disorder, social anxiety disorder. So antidepressants and analoxic medications work to balance things like serotonin, norepinephrine, and GABA, and can help with anxiety. Also, we use some beta blockers and some other types of drugs which focus on the physical symptoms of the body, like rapid heartbeat, and that can help with anxiety. And then sometimes we even use those old school antihistamines to help with anxiety symptoms because they can be a little bit sedating. So I always say with anxiety, we have to work, well, depression too, but it's just more visual for me with anxiety, that we have to work from the outside in and we have to work from the inside out. So if we can, if we work from the outside in, if we can help people with their breathing, if we can help them, with those types of symptoms, physical symptoms, then it can help the brain process the anxiety a little better. Also, if we can help the brain process anxiety a little better, then they're going to see less physical symptoms of anxiety. So SSRIs are usually the first line of treatment for anxiety for things like panic disorder, obsessive compulsive disorder, social anxiety disorder, general anxiety disorder, and post-traumatic stress disorder. We see tricyclic antidepressants, which is just a little bit different, used in treating things like panic disorder, post-traumatic stress, general anxiety disorder, and then things like anifranil can sometimes be used for obsessive compulsive disorder. And MAOIs we usually see for panic disorder, social anxiety disorder, post-traumatic stress disorder. So you can see there's different options. Buspar is an anti-anxiety medication, one that you've probably heard of pretty often. But people should be aware that large amounts of grapefruit juice may increase blood levels of Buspar. So kind of something we need to educate clients about. First generation antihistamines can be used to treat general anxiety disorder. And so that's things like Vistaril. And a lot of times we use that in detox, Vistaril, to help with some of the increased anxiety that was happening. Those are pretty low-level medications and can be used very short-term. Now, benzodiazepines we want to talk about briefly. So benzodiazepines used to treat things like general anxiety disorder, social anxiety disorder, or panic disorder. They specifically act on the neurotransmitter GABA. So things that we know about benzodiazepines, they can cause people to be very drowsy, and people should be very cautious if they're going to take benzodiazepines and do things like drive or work the forklift at work, things like that, until they know how it's really, really, really going to affect them. We do know that benzodiazepines can be addictive. And so that is something when we're dealing with clients with co-occurring disorders that we really need to weigh out, again, those risks and benefits. Benzodiazepines can be very effective for people dealing with anxiety issues. So we don't want to rule it out because of addiction potential, but we need to always be weighing those things out. We need to remind people and educate people that benzodiazepines are central nervous system depressants. So if they're taking a benzodiazepine and putting another central nervous system depressant in there, like alcohol or even marijuana, then there can be some synergistic effects that could be really, really dangerous, including making people very drowsy, excuse me, and making it very difficult for them to breathe and even overdose of central nervous system depressants, causing them to overdose and even die. So we need to really be conscientious, educating people about that. And then also just reminding, when you're thinking of your clients, are they able to be compliant? And I hate that word, but are they able to follow instructions when it comes to medications? Because when you're dealing with benzodiazepines, that's really important. So if their prescription says take one PRN, which means as needed, no more than 4 in a day, are they able to do that? Or are they going to be thinking, well, I'm really anxious, so I'm just going to take 2 at a time, 4 times a day. Now I've had 8 in a day. So we really need to look at that, their ability to be able to follow instructions and kind of the thought process they have around this particular type of medicine. Xanax, Klonopin, Valium, those are your basics. So we want to talk about, and let me say one more thing about benzodiazepines. We have seen with the opioid epidemic, which continues. So yes, we have an epidemic inside of a pandemic. We have seen an increase in benzodiazepines. Now, the Prescription Drug Monitoring Program is in Pennsylvania, is doing a lot of work to try to keep overprescribing of benzodiazepines, and then we're seeing some success from that. But when people are using things like heroin and fentanyl and they're having withdrawal, then sometimes they turn to the benzodiazepines to help with that. So we definitely know that it's out there on the black market, so to speak, and something we want to keep an eye on. Stimulants are usually used to treat children, adolescents, and adults with things like attention deficit disorder. Stimulants increase alertness, attention, and energy, as well as elevate the blood pressure, heart rate, and respiration. So mostly we're looking at things like Ritalin, amphetamine salts, Adderall, Vyvanse, these types of things. Stimulants have some really interesting history because we have a number of students who either in high school or in college will use stimulants to cram for tests, study for tests, things like that. So they use them short term. They're not using them for to really, they're using more as a stimulant, not as an ADHD medication. But we definitely see that. Now, interesting, they've done some studies over the long term and found that people who used stimulants to cram for tests, even though they did better on the test, overall their grades weren't any better than anybody else's. So I just thought that was kind of interesting. Also, we use stimulants sometimes to treat things like narcolepsy and sometimes even depression in some unique situations. So, and I think this is important to recognize that research has shown that teenagers with attention deficit disorder who took stimulant medications were actually less likely to abuse drugs than those who did not take the medications. So I think that just speaks to if there's something going on in the brain that needs to be, if we attend to it appropriately with medication, then it actually decreases other risks. If we don't treat it appropriately, then other risks then increase. So I think that's important to recognize. We are seeing a big increase in Beaver County, for example, of stimulants in general, both prescribed and illicit. So we are seeing an increase in prescribed stimulants. We're also seeing an increase in things like cocaine and methamphetamine, which obviously are not being prescribed, but people are getting them. So most side effects with stimulants are relatively minor, disappear when the dosages get into the right range. But the side effects can include difficulty falling or staying asleep, loss of appetite, stomach pain, headache. Sometimes there are also, in less cases, there can be some tics, either motor or verbal, and some personality changes. And they say this is a less common side effect, but this is one that I hear most commonly from clients or from family members of clients, is that they say that they just seem flat. They've kind of lost their personality a little bit, which is a lot of reasons why people try to allow their kids to take it only during school, and maybe in the summer they don't have to take it if they don't need that focus and those types of things. We also have mood stabilizers, which are used primarily to treat things like bipolar disorder and to help with other medications that people might be on. So these medications work the same as kind of the others. They work in the brain. Sometimes we use mood stabilizers also to treat just depression, schizoaffective disorder, and other impulse control disorders. Lots of side effects for mood stabilizers. Again, most of them go away pretty quickly, but with mood stabilizers, sometimes they don't go away. They might decrease, but not go away. So things like itching, excessive thirst, frequent urination, tremors, nausea and vomiting, slurred speech, fast, irregular, or pounding heartbeat, blackout, changes in vision, seizures, hallucinations, loss of coordination, swelling of the eyes, face, lips, tongue, etc. So actually, that word seizure there, just something jumped out at me, and I want to go back briefly to talking about benzodiazepines. So benzodiazepines are definitely a medication that someone should not stop taking abruptly. There is a risk of seizures for people in withdrawal from benzodiazepines, and that really needs to be contained. So I think I neglected to say that when we were talking about the benzodiazepines, but it is really, really important. So Paul here noted that he had lost a pretty significant amount of weight when he was on a stimulant called Concerta, and that is another thing that happens often with stimulants, because they boost the metabolism, they get everything moving quicker. So sometimes people do see that as well. Sometimes people will abuse stimulants for that reason, to try to help them with weight loss, which obviously is not recommended. Thanks for sharing that, Paul. So back to talking about mood stabilizers for things like bipolar. They can have issues. Mood stabilizers can cause problems with the liver or the pancreas. And so often doctors will recommend regular blood work to keep an eye on those things. They can increase testosterone in teenage girls and lead to things like polycystic ovarian syndrome. And then we've also seen in teenage boys, they can lead to a decrease in testosterone. And so sometimes we've seen in rare situations, teenage boys that are developing breasts because of the decrease in testosterone and increase in estrogen. So keeping an eye on things like that for young people is important. And so there can certainly be interactions between mood stabilizers and some other regular medications that people often take for things like diabetes, high blood pressure, and then other psychotropics. So it's real important. If you remember earlier, I said, I feel comfortable that most times a PCP can prescribe an SSRI and many times an SNRI. But if you're looking at MAOIs, or you're looking at benzodiazepines, or you're looking at stimulants or mood stabilizers, I prefer a psychiatrist. So that's just, again, the Jill Perry opinion. Sometimes we've used anticonvulsants as mood stabilizers, such as valproic acid, and we still do see that sometimes. But most often we see things like Lamictal or lithium. These are some of the side effects of anticonvulsants, basically the same, but a little more. Okay, so we're going to move on, because before the break, I want to get through the rest of this stuff about medications. So here's the dog doctor saying to the dog patient, let's get a sample. And he brought over the fire hydrants. I thought that was pretty funny. Okay, so let's talk about pain medications. Again, I guess I like to preface pain medications by saying that they're not all bad. I think when you work with a substance use disorder as often as I do, and many of you are in that same situation, I can get a little myopic and be like, oh my gosh, pain medication. Jen said it's starting to snow where she is. It's not starting to snow where I am in Beaver. I'll keep an eye on it, Jen. But they said 10 o'clock, so should be starting soon. Okay, sorry, back to pain medications. I'm a little excited about the snow, if you didn't notice. Okay, back to pain medications. Story that I often tell about my dear friend, Dr. Capretto, who many of us miss every day. When I had a kidney stone once and ended up in the ER, and the first thing they did was offer me morphine, and I was like, morphine? Can't you give me something a little less potent? And they were like, nope, that's what we do for kidney stones, morphine. So I went to Neil and said afterwards, I can't believe they did that. They didn't ask me about my history of substance use disorder. They just, I asked them for something less intense than morphine, and they said, no, that's what it had to be. And I was frustrated by it. But what Neil reminded me is that a kidney stone, for example, needs to pass. And he said, when you're in pain, your body tightens up. Everything's tightened up, right? And so there's no way that kidney stone's going to get out when everything's all tight. So that pain medication can allow the body to relax and allow the healing to happen. Same thing after surgeries, like medication, pain medication after surgeries can help the body relax so that the healing can happen. So there's really good things about pain medication. I think in our world, it gets a bad rap sometimes. Pain medications specifically act by blocking the receptors in the brain, the signals in the brain that tell you we have pain. They are they can be misused, often are, but most painkiller use is not misuse. And I think that's a perspective we need to remember. They can be habit forming. They can move into substance use disorder, and they can be deadly at high doses or if mixed with other medications. So some of the things we see for pain medications that are non-narcotic would be things like Celebrex, Ultram, which is still, I guess, a little controversial, Demerol, Lorcet, Vicodin. Those now you're moving into things that are narcotic based, but not all pain medications are. And then here's a list of some more, including Norco, Percocet, Percodan, Oxycontin, and Opana. MS Contin, fentanyl, and Dilaudid. Fentanyl is sometimes used as a prescribed pain medication under certain criteria. Okay, so if we look at the statistics, more than 1 in 3 American adults, that's about 35%, were given prescription pain medications by medical providers in 2019. More American adults use prescription painkillers than cigarettes, smokeless cigarettes, or cigars combined. So this gives you an idea of the numbers. Then women are more likely to have chronic pain, to be prescribed prescription pain relievers, to be given higher doses, and use them for longer periods of time than men. Women may become more dependent on prescription pain relievers more quickly than men, although we see them less often in treatment. And so I think those are things we need to just ponder about what's happening differently. And I have some different opinions about why women are more likely to have chronic pain, why they're more likely to be prescribed pain relievers. There's lots of different cultural and other reasons, biological reasons why that may be. We're not going to get into those today. We could do a whole session. Maybe we should. Opioid painkillers killed nearly 19,000 Americans in 2014. I should really, oops, these some. That number is greater than the number of Americans that were murdered in 2015. So I just try to give some perspective. And then in 2008, Americans consumed about 80% of the global opioid supply and 99% of the hydrocodone supply. Pretty amazing, huh? And it hasn't gotten better, unfortunately. This year in Beaver County, we have seen an increase in opioid overdose deaths over last year, which is unfortunate. Much of that, I'm sure we're contributing to just the changes in the world because of COVID. But we still have to do better, right? COVID or not. Okay. I wanted to talk briefly about some herbal products. So I had said earlier, we talked about the FDA and what they regulate. So the FDA does not regulate herbal products. So what that means is when you go to the store and get an herbal supplement like ginkgo biloba, and it says, 100% ginkgo biloba. Well, no one is regulating that that's really what that is. So you may get 100%, you may get 5%. Now, many companies have their own internal quality control. So this is not to say that nobody's giving you what they say they're giving you, but you have to be conscientious. Where I see this most often is people take melatonin and they'll say, well, this bottle, I had a bottle of melatonin and it worked great, but now I got a new bottle of melatonin, it's not working at all. Well, it might be what you're getting in each little individual capsule. It is important that people share with you as a clinician and share with their doctor any herbal supplements that you're taking, because they can have an impact on various medications. So it's important. And these are just some of the side effects, the negative side effects of some herbal products. So like St. John's wort can have some gastrointestinal issues, some allergic reactions, fatigue, dizziness, confusion, photosensitivity. So there's not, again, these don't always happen, but these are possible. There are some interactions. So when we talk about making sure that your clients share with their doctor, things like ginkgo biloba should not be used with people who are on blood thinners like warfarin or Coumadin. St. John's wort can interfere with antidepressants. Ephedrine can interact with things like caffeine, decongestants, and other stimulants. So those are just important things. It's just important that people talk to their doctor and are really open. Sometimes they think, well, because I got it over the counter, it's not important to share, but it is. So I want to talk quickly about medication-assisted treatment, counseling and support connected with the medication, like Suboxone or Vivitrol. This is often still found to be the best option for dealing with substance use disorder, opioid use disorder today. And so I think still some people are still coming around and still have some questions about it, which I totally respect. But the studies are really showing that this is the best way to treat people with opioid use disorders for the most part. So methadone, buprenorphine, naltrexone. I think you're all pretty familiar with these. Methadone is usually daily. It's oral, and usually dosing is done with staff at least initially, and then some people can work up to taking it home. There's no real time frame set on methadone treatment. No really best practice. You should be on methadone for a year. You should be on methadone for 10 years. I would say that's one of the downsides, and is usually the minimum is usually a 12-month recommendation for maintenance, but there's no maximum or those types of things. So buprenorphine or Suboxone, doctors have to have a special certification to be able to prescribe. Subutex we're using primarily for pregnant women. Suboxone is the buprenorphine mixed with naloxone. Buprenex is the injectable available, and then the Butrans is the 7-day patch. Okay, so MAT, we talk about the most effective is when you have the medication coupled with counseling. So there are counseling requirements for methadone. I think it's 2.5 hours a month. There are requirements for things like Suboxone. Many of those have been lifted or they just haven't been followed through with during COVID for multiple reasons. But when I look at clients that I've worked with, it's interesting to me because some of my clients who are on Suboxone, for example, who say, well, my doctor says I don't have to come to counseling because of COVID, but I still want to come because I'm still really trying to stay clean. They see the value in it. So even though it's not required in the moment, they're still doing it. And then I have other clients who are like, I'll see you when the doctor says I have to come back. And so then we have naloxones with Revia, which is a daily pill, and Vivitrol, which is the monthly injection. We have some medications that can help with alcohol. The Vivitrol sometimes helps with alcohol, and Campril and abuse. Now those aren't used as much anymore as they used to be, but they are still available. And so we should touch base briefly, at least, on Narcan. So Narcan, I think most of you are aware, is an opioid overdose reversal agent. So it blocks all those receptors in the brain that are for opiates and kicks it all out, keeps people who may be in the process of overdosing from completing the overdose, which is, it's available right now mostly in the nasal spray. There is a standing order in Pennsylvania, so anyone can go to the pharmacy and get Narcan. And most insurance companies will pay at least a portion of it. We also have a Good Samaritan law in Pennsylvania, which means that if I administer Narcan to someone, then I'm kind of off the hook. Although we have found no side effects or negative side effects from Narcan. But if someone's going to sue me because I gave them Narcan, I have some protection. The Good Samaritan law also gives protection if I'm using with, let's see, who's here? Melanie, my friend Melanie. If Melanie and I are using together and Melanie starts to overdose and, passes out, I can call 911 and I'm not going to be arrested because I'm using with Melanie when I make that call. Now, if I have outstanding warrants or I have a bunch of guns that aren't registered on me, or I'm a human trafficker, those things I'm not protected by the Good Samaritan law. But if I want to call and get my friend who is overdosing help, then I'm protected from that in that moment. Beaver County, through BCBH and the District Attorney's Office, has programs to get Narcan out to the community, particularly to providers. It's looking a little different right now with COVID, but if you're interested, you can call or contact BCBH, or if you get in touch with me, I can make sure I get you to the right people, and they can make arrangements to get you any training that you or your staff may need, and also distribution of Narcan if you're looking for it. Okay. So we're going to talk about medical marijuana, and then we're going to wrap up for a quick break. So these are the diagnoses in Pennsylvania right now that medical marijuana is legal for. So sometimes people say they're getting it for various things when it's just not even legal for. So let's watch this quick video. Jen, you're going to yell out to me if you can't hear the audio.
Have legalized medical marijuana, though. It means our country is almost now officially half-baked. Our state, California, was the first to legalize marijuana for medical use, but we aren't so strict when it comes to why doctors can prescribe marijuana. So I thought this would be a good idea for tonight's pedestrian question, especially with 420 coming up. We went out in the street and we asked people very straightforward, do you have a medical marijuana card? Now, the way this works is we'll see somebody introduce him or herself. Based on that introduction, we will guess they have the medical marijuana card, and then we'll find out why they have it. Okay? Let's begin.
What is your name and where are you from?
I'm Randy, and I'm from Hollywood, California.
Do you have a medical marijuana card?
All right, look at Randy. Does he have a medical marijuana? With a couple of naysayers. Let's find out.
I sure did. Yeah, you kind of need one to have medical. Yeah, I guess you need one, huh?
Yeah. This is for short-term memory loss, I think. I think if your name is Randy, they just give you a card, no questions asked. Who's next?
What is your name and where are you from?
My name is Joy. I'm from here in LA.
Do you have a medical marijuana card?
What about Joy? Mostly, more than half say yes, the rest say no. Let's see.
I do. The condition is children, job, life.
One of the best reasons. You know there's a 0% survival rate on life. Who do we have next?
What is your name and where are you from?
My name's Joshua J. Miller. I'm from Salt Lake City, Utah. Represent 801. You know what I'm saying? What's up, you guys? How you doing today?
Do you have a medical marijuana card?
Josh from Utah have a medical marijuana card. Surprisingly, more no's than yeses. Well, let's see.
You know what? Do you want one for my birthday or Christmas?
How long has it been since you smoked?
How long? Since I was 13 years old. Oh, I've been smoking all day, girl. Like. This is nice. Spin and smoke. JK, wrap around. We're looking at pop time.
I would say the only two words I understood we're popping tarts. All right, who's on the stand next?
What is your name and where you from?
How y'all doing? I'm Demetrius from Savannah, Georgia.
Do you have a medical marijuana card?
Does Demetrius from Savannah have a medical marijuana card? Let's find out. Yes, I do.
How many homes do you have?
Glaucoma.
What does that mean?
It means that in the future, that it's a possibility that I could have glaucoma. It's a certainty that he has pot. Technically, we all have such like glaucoma, don't we? Experts in it.
What is your name and where you from?
From Denver, Colorado.
Do you have a medical marijuana card?
What about Bob? Oh, everybody's pretty much saying yes. All right. No public service. To buy his dad medical marijuana. Next.
What is your name and where you from?
I'm Justin Harrison, and I'm from Los Angeles, California.
Do you have a medical marijuana card?
All right, that's Justin. Oh, most of the audience is saying no. Okay, well, let's find out. No,
Why not?
because I don't believe in using them.
What's in that fanny pack?
My bus pass, crackers, my phone, my charger,
What kind of crackers?
Ritz crackers.
Can I have one?
Sure.
Thank you.
What a beautiful
All right, I thought we could all use a little bit of a laugh before we went off to the break. So, medical marijuana, the last couple things I want to say before we go on the break is, as all of you have seen, it's really changing the dynamic of what's happening with clients. So, I have a number of clients that come in and they're on medical marijuana, but they don't have a card, and they don't fit one of the diagnoses. But they kind of see this as a free pass to use marijuana. And so what I try to focus on with those folks is if they're using marijuana medically, then when we use medicine, we really should follow the rules. You know, if the doctor says, here's the antibiotic you take and you take it for 10 days, and then we really should take it for the 10 days, right? And so the same with medical marijuana. You know, what is the doctor's recommendation? Because doctors can't write you a prescription for medical marijuana. They just give you a recommendation in Pennsylvania. And then what is the, you know, when you go to the dispensary and get legal marijuana, you know, if you're following the rules, then that says a lot. If you're getting your marijuana from Bob down the street, whether you have a medical marijuana card or not, you're not really following the rules. And so that's what I kind of focus on with people. At the same time, I have seen medical marijuana do good things for people. So you know, again, back to our good friend, Dr. Neil Capretto, he wrote an article years ago that said we should not smoke our medicine. And it was about how we should not be using marijuana for things. But that was changing over time. Even before he was gone, he was starting to recognize too that sometimes marijuana can be very helpful for things like depression and anxiety. Now, it doesn't always need to be smoked, and maybe that's still his point, may still be valid, that maybe we still shouldn't smoke our medication. There are other ways that we can take it. Paul said it's snowing, and I see it is snowing here in Beaver. So excited. But medical marijuana can be helpful. And I will say, again, Jill Perry opinion, the environment's going to continue to change. You know, Pennsylvania is trying to make marijuana recreationally legal, and that I'm not sure that may or may not happen. I think it probably will, but we might still be a ways off. But that's going to change the environment even more. But Beaver County in itself is really trying not to criminalize the use of marijuana as much as some other areas, although people need to be responsible. So we have a lot of people getting DUIs, for example, because they have marijuana in their system. Those things are still, safety issues that we still have to be aware of. So that's everything I think about marijuana. If you have questions about anything we talked about this morning, go ahead and put it in the chat and we will touch base on it when we get back. Then when we get back, we're going to talk about special populations, and we're going to talk a little bit more about how to, some of the cognitive behavioral sorts of ways to help clients do better with their medications. So thank you guys so far for the morning. At this point, hey everybody, welcome back. Gotta get myself situated. I was busy, taking care of things during the break. Okay. Jen, you can hear me okay?
You're good.
Excellent, thank you. Yeah, so the snow is looking nice. It's not really laying too much here yet, but I guess they're calling for a significant number of inches, so we shall see. During the break, I already had a patient that I had scheduled tonight at 5 in the office text me and say, if the weather's bad, I'm not coming. Like, that's fine. We'll reschedule. That's fine. Okay, so moving on. Before we go on to our next section, does anybody have any questions, comments, or thoughts about anything that we've talked about so far this morning? So hopefully, I know for a lot of you, it was probably a recap. I find sometimes recaps are good, like just friendly reminders of things that we know that we just lose sight of sometimes. So I don't think that's too bad. And for some of you, maybe you learned something a little bit new, but I think it's important stuff for us to know when we're working with patients. So let me get my screen back up here and, whoops, this one. We are going to move forward. Okay, so we're going to talk about some special populations because there are some things that we need to be conscientious of when we're thinking about medications. Some groups that just take a little bit different or more attention than some others might. So, for example, when you're working with children and adolescents, so children and adolescents respond to medications differently than adults. They're not just mini adults. So sometimes the medications have to be different for them. And so we need to be conscientious about that. There are some medications also that actually are not approved to use with children. So a doctor may prescribe them as off-label, but they may not. So it may be a little bit limited. Just based on the complexity of the way their bodies are developing, the brain isn't fully developed yet, things like that. Medications can definitely react differently with younger people than it can with us as adults. And we particularly see some of those black box warnings about suicidality as it being most significant for younger people. And when I say younger people, I mean up, some of you, but up to, let's say, age 25. So that's where those black box warnings, we seem to see them the most impact, although that's not all, but that's where we see it the most. On the flip side, we have to look at our older generation. And when I say older adults, we're going to talk about people that are 65 and older. And there's some specific medicine issues that we want to be prepared for when dealing with older adults. So because of the way their body is changing, different than from kids, their body's fully grown and now starting to, in some ways, deteriorate. So they have a potential for some additional drug reactions that might not happen for the bulk of people there in the middle. We also find that older adults often miss doses, don't take the meds as prescribed, so they risk some overdose and some of those types of things more. And so just remember, this is true when we deal with, this is why we're seeing an older population, our older population having significant issues with substance use disorder with pain medications, is because the body doesn't metabolize those medications the same way as it did when they were younger, like me, 50. And so, or, 30, when people, younger even than that. And so we need to be prepared for that. And so sometimes it's taking doctors some practice to come up with the best appropriate doses of things like pain medications for older adults so that they can have relief, but also not increasing their risk for substance use disorder so much. So older adults purchase more than 30% of all the prescription medication and more than 40% of all the over-the-counter medications. And the estimates are that as many as 90% of seniors use some sort of herbal remedies or vitamins. So, excuse me, something to keep in mind when you're dealing with an older population. And they say that seniors take an average of 4 to 5 medications on a daily basis. Now that may include some herbal remedies and some vitamins. That's definitely something to think about if you're working with that population. We did touch base on women who are pregnant or nursing or considering becoming pregnant, and we need to be just very conscientious and some extra support and questioning for those women to make sure that they're protected and that their fetuses are protected, or potential fetus. So some of the risks for pregnant women: mood stabilizers have been known to cause birth defects. Benzodiazepines and lithium, which is a mood stabilizer, have been shown to cause what's called floppy baby syndrome, in which a baby is drowsy and limp and can't breathe on its own or feed well. Benzodiazepines may cause birth defects or other infant problems, especially if taken in the first trimester. And of course, we can't forget that women who are using certain medications, the baby may actually be born with withdrawal symptoms, which can be very risky for the baby. Antipsychotic medications have some issues with birth defects and some other things like that. So definitely, if you're dealing with women that are in childbearing age, and that can be pretty young now. So I think girls now, the average age where they start menstruating is now down to 11. So even those of you working with youth and children and youth have to be kind of anticipating these types of things. For girls as young as, let's say, 10 or 11. And then, even women going through menopause can sometimes still get pregnant. This is very, very scary, I think. But so women up into their 50s and potentially beyond, who knows? Let's see. Okay, so there's some more things about pregnant women. Sorry, I'm just running through, trying to touch on the basics. You can get any of the slides that you want, you can get from when you email Jen or when you can get them. So medications can sometimes pass, psychotropic medications can sometimes pass through milk or through nursing into breast milk. And so that sometimes is an issue and sometimes is not. And so that's where a conversation with a doctor, and there's lots of, I'm a big advocate of nursing. It's not absolute. I mean, many healthy babies are not nursed, but there are a lot of really good natural benefits from it. So I'm a big advocate. However, you have to kind of weigh out the risk versus the benefits when you're dealing with those kind of things. Let's see. So Paul asked, do you know if men on medications for mental health have an effect on the couple's baby? So there haven't been a lot of studies about that. So if a man is on an antidepressant, for example, and impregnates a woman, there hasn't been a lot of studies on that. And the studies that we've seen haven't really shown any big issue. Now, the bigger issue is not so much from medications, but is about the genetic stuff that gets passed on. So if you're dealing with You know, we know things like schizophrenia, for example, sometimes do have a genetic network to them. So that might be passed in the genetic makeup there, but not necessarily from any issue with the medication. So good question. Okay, so moving away from pregnant women, nursing women, women who may want to get pregnant, there are certain cultural groups that respond differently to medication. So for example, African Americans and some Asian Americans metabolize some medications more slowly than Caucasians. And so they have a higher risk of certain side effects, and they actually may be able to do better on lower doses. So that's something to think about. And many ethnic groups, treatment is also complicated with language barriers, socioeconomic stresses, lack of minority healthcare professionals, and stigma. So we have to remember all those things. Those are all things that we can focus on and try to help with. But that can definitely be an issue when we're dealing with certain cultural groups who are looking for medication. Trying to really educate them, particularly if there's a language barrier or some cultural ideas that are different than ours. So we did touch base on this earlier. Who should prescribe mental health medications and or pain medications? You know, again, my philosophy is many of my patients who are looking at an SSRI or even an SNRI can usually go to their PCP. Sometimes I have had them sign a consent. Well, actually, most of the time I'll have them sign a consent. But sometimes after that consent is signed, I'll try to talk with the doctor because, you know, my philosophy is this. I get to spend like an hour a week with my clients, you know, here and there. A doctor gets to spend like 15 minutes with them every couple of months. So sometimes I have some good information that can help them, never overstepping my boundaries and saying, this is the medication I think they should have. But sometimes I can say, you know, based on these things, this is kind of what makes sense to me. But hey, you're the doctor, so you make that decision. If you're dealing with clients that have multiple medications or that have certainly need MAOIs, if they're resistant to medications that their PCP has prescribed, if they're looking at ADHD, things like that, then I definitely move them on to a psychiatrist. And then there are some pain specialists out there that have some programs that combine both the physical and the emotional part of pain. And so that can be very helpful if you're dealing with someone who has chronic pain issues. And then of course we have some addictionologists who are doctors who really studied substance use disorder, and they're the best to kind of handle those co-occurring clients. But they're hard to find. But they are hard to find. So recently, when it comes to medication treatments, I did want to mention this. I learned recently that at UPMC, they are offering ketamine treatment for people with medication-resistant depression. So the treatment lasts about a month. It's twice a week. They go down to the facility twice a week. It takes about 2 hours. The client actually administers the ketamine nasally themselves in front of staff, and then they're observed for 2 hours because obviously there can be some dissociation. And then once they're released for the day, they're not allowed to drive the rest of the day, but they can go about their business. And people are saying that they're feeling relief from depression after the very first treatment. So it looks like some pretty incredible stuff. Now, ketamine is a treatment that requires maintenance. And so after the 4 weeks of twice a week, then they start to work with each client to see, can they do it once a month? Do they have to keep it twice a week? Can they do it once a week? Then they figure out what the maintenance dose is for the client. So it's pretty cool stuff, I think. Pretty cool stuff. So I want to spend time talking about helping our patients manage their medications. And it is a skill, and some patients don't have it, right? Sometimes it's a skill that we have to really teach people how to take their meds on a regular basis, how to remember to take it, how to deal with side effects, how to make good decisions about their medications, how to take good notes, and keep records about their medications and things like that. So I always encourage clients to make a list of all their medications, including vitamins and herbal supplements. Keep it in their wallet, keep it in their phone. Sometimes my clients will keep it in their phone. I certainly keep a list as well in their record, but I think it's good for them to have a list with them at all times so that if they end up in the emergency room, excuse me, and a nurse or doctor says, "What meds are you on?" They're not like, "Oh, I think this, I think that." This actually happened to me recently. I took my daughter to the eye doctor last Saturday, and when we finished her appointment, I said, "I want to schedule myself an appointment." And they said, "Well, we could see you right now." And I was like, "Okay." So, but when I went into the nurse, she asked me my meds and I listed them, but I forgot one. And so she looked at my med list from 2 years ago when I was there last, and she said, "Well, you're not taking this anymore." And I was like, "Oh no, I am taking that." But if I had pulled out my little list, it would have been much, much easier. So we definitely encourage clients to keep that. And then beside each medication to really write who is the prescriber. Now, maybe it's best if one doctor is prescribing everything. That's why when we have more complex cases, people on multiple medications, sometimes it's best that the psychiatrist just does everything. But sometimes there is a collaboration between the psychiatrist and a PCP or maybe even more doctors prescribing medications. So we need to be aware of that. Talk to patients about pharmacy shopping and about trying to find a pharmacy that works for them and staying with it. That can offer them a lot of support. Keep them from abusing things too, but it also can offer them support because pharmacies will sometimes call if they haven't picked up a prescription. They will let them know when a prescription is about to run out. They can be a nice, helpful reminder. Plus, they can offer good information about, make sure you don't eat this food when you're on this. Make sure you don't drive till you know how to react to this. Those types of side effects and drug interactions that they're another good resource to help educate our clients. Encourage people to throw away medications that are outdated. And across the county of Beaver now, we have medication return boxes everywhere, every police station and other places too. So there's really no excuse. Just get rid of them. If they're out of date, get rid of them. And then encourage people not to borrow or lend medications. This is more rampant than I ever realized, how people share medications and, well, why don't you try my med for a week? And if it works, you can tell your doctor you want that. So to really encourage people that is not wise for a multitude of reasons. Not to skip doses, but to know what to do if they do skip a medication. So some medications say if you skip it, then take it when you realize it. Some medications say if you skip it, just wait till your next dose. So to know if you do, for each medication that a client's taking, if they miss it, what they're supposed to do. Check, and recheck. So before taking a medication, double check the label, make sure they're taking it correctly. There have been incidents where people get the wrong medication from the pharmacy, where I just read recently, oh gosh, I don't remember what medication. It was a psychotropic medication that was recently recalled because it was mixed up with erectile dysfunction medication. But I don't remember what the psychotropic was. But so that happened at the factory. So those things can happen. So to really, and if, my pharmacy always says this medication might look different this time. They put a little label in there that says the medication may look different this time, but it is the same medication. So if they're getting it from a different generic prescriber or generic factory, then the pill might look different. And so they're alerting you that, yes, it looks different than it did last month, but that's okay. So those types of things are, if you ever look at your pill and it doesn't look like it looked last month, then you should be asking the pharmacy if they don't have that little label in there. Take the pills the same time every day. Pick a time when you're almost always home. And I encourage people to, this works for me, is to connect your medication with something that you do every day. So my medications are morning meds, and I take them when I brush my teeth because I brush my teeth every morning. That does not, there's not a day that I don't brush my teeth in the morning. Even if I'm not going to get out of my pajamas and take a shower, I still brush my teeth. So that's my connector. I brush my teeth, now I take my meds every single day. So if they can connect it to something like that, it can make it a little easier for them. Some automated reminders. A lot of people are setting reminders in their phones, and so that can be really helpful too. We want to talk to clients about being open with you and being open with their doctor about medications. So making sure they tell their doctor all the medications and any supplements that they're on and things that they're taking that they're not supposed to be taking or that aren't prescribed. So, you know, like particularly with us, like I encourage clients to tell me, you know, well, I took 3 of my, you know, the Oxycontin that my grandfather had in his medicine cabinet because my shoulder was hurting the other day. You know, I know it's not prescribed and it's, you know, but there's no judgment here, but we need to know the whole picture. And so does your doctor, actually. So remind your doctor of any allergies or any problems you've had with medications in the past, and be willing to listen to what your doctor says about that. Because remember, sometimes when we have a reaction to something like an SSRI, we may not have the same reaction to a different SSRI. And so if the doctor says, no, it's okay, go ahead and try this, this different one, you know, to at least be open to it. Understand how to take your medicine before you start using it and make sure that you take it as instructed. And sometimes clients are on medications that they have to take multiple times in a day. And so that can be tough. And then to encourage a safety plan with each client of what they're going to do if they have any problems with their medications. Make sure they have that poison control number. Make sure they have the number of their doctor maybe in their phone as a contact so they can call right away. Those types of things so that they have a plan. If, you know, my philosophy is always hope for the best, but prepare for the worst. So medication compliance, you know, I get frustrated with the word compliance because compliance tends to be like, I don't know, it just is a harsh word to me. But that's the word that we sometimes use. So I think it is important to note here, this part that I highlighted, that compliance tends to be a problem for all people with long-term medical conditions, whether their conditions are mental or physical. So people, you know, we talk about people who are taking antidepressants who start to feel better and stop taking the medicine. We have the same issue with people who have high blood pressure and take that blood pressure medicine and start to feel better and stop taking the medicine. We have, you know, the same type of thoughts that go through the head happen whether it's a physical medication or a mental health medication. So I think that's important for us to remember is this isn't particular to our patients. This is particular to all of us because we're human. And if you even look back, each of you at your own histories, you can probably pick out some times when you maybe were a little sloppy with your medications of various types. And that's somewhat human nature. That's what we're working with there is human nature. So now demographic factors such as whether you're single or in a relationship are more likely to play a role in compliance than whatever the issue is. So I always think that's kind of interesting. So they find that people who are partnered up tend to do better at being compliant with their medication. I certainly see that in my relationship because my guy who is a type 2 diabetic, he has to take medication at dinner. And I'm constantly, you know, did you take it? Did you take it? I'm constantly bringing it to him. Look what I found. You didn't have to take a pill. So, you know, if nothing else, there's 2 of us that are attending to him taking that medication instead of just one. And so there's some power in that, right? So those types of demographics tend to show us more about compliance than what the actual disorder is that they're taking the medication. So poor Dr. Spock, or not so Dr. Captain Kirk, poor Dr. Kirk, Captain Kirk there. Preapiism, a painfully hard topic. So this is what you hear on those commercials that say, if you have an erection for more than 3 hours, you should go to the doctor, call the doctor. So that's what the official term for that. So it's not as fun as you think. Okay, I have this video here that I wanted us to watch. This is a young woman who's talking about her experience with bipolar and her medication issues as part of a blog that she does. And I just found it to be very helpful. And I think it's helpful too to hear right from individuals instead of other providers sometimes. Let's take a look at her.
I hope you're having a great day. Thanks again for stopping by my blog. Today's topic, I want to talk a little bit more about medication compliance with bipolar disorder. I want to thank a fellow YouTube subscriber that asked a question about medication and asked me to do a video on medication compliance. I encourage all of you to ask questions, leave comments, and I will do videos on answering those questions. So I want to talk a little bit about medication compliance. And when I think back over the last 11 years, I can say that probably me staying on medication has been the most difficult. And there's a lot of reasons why. So I want to start with my experience with medication, why people think I don't need medication, including myself in the past, and then tips that I use to help me stay on my medication and make sure that I'm not skipping doses. And I think the biggest thing for me at this point is that I've seen this happen in the past that I need medication. So, think about it, if I had diabetes or high cholesterol or asthma, I'd be taking medication. And for whatever reason, we have this program in our head that mental illness is not the same as diabetes or any other sort of disease. And it is. So the sooner that we realize that, the sooner that we take ownership of it.
All right, we're going to go ahead and move on from her, unfortunately. So maybe what I can try to do is get the link to that little blurb. It's about 8 minutes. Maybe I can try to get the link over to Jen that she could get out to you guys, because I did find her in particular really, just really good to hear from, straight from the horse's mouth, so to speak. So a couple things that she talked about that I'll just touch base on. She talked about the dynamic of feeling better and then also sometimes feeling a little angry that you have to take medication, and so being a little rebellious and stopping taking it or not taking it on a regular basis. And then kind of what she talked about in her experience is she wouldn't take it as prescribed, and then that would reinforce this thought in her head that it didn't work anyway. And if you're not taking medication the way you're supposed to, then it's not going to work as well as it's supposed to. So that's a dynamic we see a lot of times with clients, more often with things like mood disorders, like bipolar, for example. And that's specifically what she was talking about. When people are manic, sometimes that actually feels pretty good. And so then they're like, I'm fine. And so when they get back into when they slide back down to the other part, it's a little different. So that's one of the phenomenons she talked about and what her experience was that I thought was really, really important. So I'll try to get that link out to you. I don't know what happened there, but I got a little message that said the host muted me.
I think it was me. Sorry.
And then it said the host wants you to unmute. Well, then don't mute me.
Sorry.
That's all right, Jen. That's okay. It's the snow. It's making you do crazy things, right? Okay, so cognitive behavioral therapy is one of the therapies that they found to have the most success in helping people be most compliant and get the best out of their medication that they can get. So some things that you can do is to ask the client about their previous experience with medication. What's their history of medication? How was it? Why was it prescribed? Was it helpful? Under what conditions did you stop taking it? Did you take it as prescribed? All of those things can help kind of give you some perspective about the client's history. And then you can kind of work through from there to help them make some decisions. Talk with clients really about their concerns about the medication, and do that in a way that's non-judgmental and that is not condescending. So the reason I say that is patients often will say, well, I don't want to take the medication because I don't want to gain weight. And I remember one time saying to a client, listen, you know, if you're going to gain weight from the medication, it's not like you're going to wake up one day and have gained 20 pounds overnight. You know, it's going to be gradual. So let's keep an eye on it. The way I presented it to her, she came back the next session, and because we have a nice rapport, she came back the next session and she's like, I got to tell you, I was pretty annoyed with you last session. And I was like, me? And so she shared that the way I expressed that to her, she found to be condescending, as if I was like as if I knew something that she didn't, and I was kind of talking over her as if she was stupid. And I was like, oh my gosh, well, I would never intentionally mean to do that. So I was apologetic, and so then we kind of rephrased. And then after we talked about it again, she's like, well, that makes sense to me. She said, you're right. I'm not going to just wake up one morning and be 20 pounds overweight, but that's my fear. She's like, so, but if I start the medication and I weigh myself every week, you know, then we set a cutoff. So we said, if she gained 5 pounds, then we were going to take a look at it. Because she thought that a 5 pound weight gain she could kind of handle. And so when I say don't be condescending, I was going off my own experience there, where I did not mean to be by any means. But in a way, she's probably right. I probably have said this conversation to people who are concerned about weight gain so many times that in my mind, I'm like, why do I have to go over this again? But it's a different client, and that's their experience and their concerns. So really listen to your clients about what their concerns are, even if they, you know, for example, I had a gentleman once who was like, I don't know, sexual side effects. And I'm thinking in my head, you're not even in a relationship. But still, there's more to it than that, right? And so to kind of explore that with him, and what would be acceptable and what would not be acceptable, you know, and that was a reminder to me too, that, you know, our sexual identity is more than just when we're with a partner. So to really take that in mind and hear that from him. So those things are important to help people with misconceptions about the medication. So the more we ask them about their concerns, we can kind of help them rule those things out and think those things through, and clarify things, and set some kind of thresholds with them, like I did with the young woman with the weight gain. If you hit 5 pounds, then you and I are going to make that an issue. You know, we're going to really focus on that. Then if it's 2 pounds or 3 pounds or no pounds, then there's no point for us to focus on it. So those types of things. Patients should be encouraged to expect gradual rather than all or nothing changes. So this is a tough one, because I think it's tough for us too, because I would like my patients to be able to take medication and just feel better, but it doesn't work like that. And so to help them with their expectation that it's going to not change the circumstances of their life, but hopefully make the playing field a little more level so that they can deal with it a little bit better. But that's a gradual process. And then to remind people too that the medication is not an all or nothing. It's not a softer, easier way necessarily. So the medication, what we do know about psychotropic medications is they are most effective when they're combined with therapy. So some people can take medication without therapy and have success, have positive results. they're going to have more positive results if they do couple that with therapy. And some people aren't going to feel the benefits of the medicine without therapy at all. So to really encourage clients about what their expectation is and what they're willing to do to get the best results from the medication that they can. And then use that as a tool to help them move on from there. Someone sees my cat, I see. Yes. Hi there, Leo. This is Leo. He's such a good boy. Now, when you're doing sessions, virtual sessions with clients, you should never have your cat loose in the room because as cute as he is, it can be a little disruptive. But I thought with you guys today, I would let him run around and do his thing. I did have a patient once. One time he was hiding in my room. Usually when I do sessions here at the house, I close my door and the cat's not in there. I have a little note on the door for the kids, leave me alone. I'm in session with a heart. It has a heart on it. But one time Leo was hiding under my bed and I didn't know it. And so while I was in session, he kind of did like he did there, kind of looped up. But my patient I was working with, who is extremely depressed, when she saw him, her whole face lit up. It was like the most amazing thing. And she was so excited to see him. And I think that's a good reminder to us about how therapeutic that animals could be. They are the best, that's for sure. Okay, so there's Leo. He's over looking out the window now at the snow because he's fascinated by the snow. So medications. I ask clients who are on medications about their medication almost every single session that I see them. And I tell them at the beginning, there's certain things I'm going to ask you every time, and just be prepared. Sometimes clients come in and they're like, yep, I've taken all my medicine the way I was supposed to since last session. You don't need to ask. Okay. It just becomes a normal process. What I have found is if I don't ask, then they're not going to tell me. So they're not going to probably come in and be like, hey, by the way, I have not been taking my medicine the way I was supposed to, unless I ask them. And sometimes I can tell when clients aren't taking their medications based on their behaviors. But sometimes that's a little too far. Like we don't want it to get that far. So being consistent with them, it's some accountability for them that someone else is going to ask them if they're taking their medicine the way they're supposed to, and make them and think about it. And then if they're not taking it regularly, what's the issue? Is there some financial issues? We've worked with patients, I'm sure you have as well, who financially struggle to pay for them. So I only take it every 3 days. Do those, so are there some financial barriers that maybe we could try to find some solution to? Is it remembering? I have people on shift work who really struggle with, I'm supposed to take it 3 times a day, but when I'm working midnights, what does that mean? So trying to really help people, what's the barrier that's keeping you from, and maybe it's not, maybe it's concrete like that. It might be something not so concrete, something like, I just really wish I didn't have to take this medicine, or being a little bit rebellious, or somebody ticked me off, so haha, I didn't take my med. Those types of things. So trying to figure out with them and then brainstorm and identify ways that can help them to be more compliant, and reminding them that the more compliant they are with the medicine, the better effects they're going to have. And that's what we want for them. So I do tell my clients, I do try to praise them when they are doing well. So that's some positive reinforcement to encourage them to continue to do that. So another place where we use some CBT is to really help clients connect some of their medication compliance or non-compliance with success or lack of success. So if clients are, if they're having anxiety issues and they're taking their medication as prescribed, and they had a situation where they were able to go into a social situation with less anxiety, well, then definitely praise that, and help them connect. The medication may have been part of that helpful part. part of what helped that along. So to really help them see that, and then also to help them see the other way around, that, you know, person comes in and they had a big fight with their family, and they don't know why they got so annoyed so quickly. Well, you know, you haven't been taking your meds every day like you were supposed to, but maybe that's the connection. Maybe there's a connection there. So to help them put those things together in a cognitive way that can help them change their behavior. Look at problem solving for non-compliance. So we've kind of talked about all these practical strategies we want to encourage people to use. We want to be non-judgmental. You can even use some self-disclosure if you're comfortable with that and you feel it's appropriate and you think it might be helpful for the clients. You know, one of the stories I often, where I have shared with clients when it was appropriate, was that my mother always took Zoloft every other day. Now, this was years ago because my mother has been gone for several years now. But I used to tell her how silly that was, that it wasn't even a therapeutic dose, that, you know, it wasn't doing her any good. And so why was she taking it that way? And she was insistent, and she had talked with her doctor, and that's the way she was taking it, and that's all that was helpful. And then fast forward years ahead, when I started taking medication for cancer, tamoxifen, which has a number of, like, I always say it had to be created by a man because, no offense, but everything that women, as women, we try not to be, like, too emotional, too angry, too stupid. It, like, brings all that out for you. And so my doctor said, let's start using some Zoloft, take it every other day. And that's the sweet spot. And so I tell that story sometimes to clients to help them recognize that sometimes we have to try something different. You know, sometimes what is normal or what worked for someone else maybe isn't going to work for us. And for us to kind of be open to that. I wish, looking back, I had been more open to that with my mother in her situation. But I wasn't, but I wish I would have been. So if there's appropriate self-disclosure about some medication issue that you have, then that you're comfortable sharing, and that, again, self-disclosure is always about, is this going to have a positive impact on the client? That's the only reason to do it, right? Then that can be very helpful. So we can use motivational interviewing when we're also helping people with medication compliance. So helping them assess their stages of change. And that would be, now, if you remember, if you were at our stages of change program, we have to identify stages of change for each different disorder, and then also for each different medication. So if someone's on 3 different psychotropic medications, their motivation for each may be in different stages. So we have to kind of take a look at that, but really assess where they are, the stages of change, help them with some empathy, help support their ability to make decisions. You know, they have a choice and they have a voice. To help them kind of point out things that may not connect. So I was talking to a client earlier this week who his wife wants a divorce. He's in a very difficult situation because he does not want a divorce. And he said, and this has been going on for some time, but he was saying earlier this week in session, I just want to be happy. And I said, well, you know, you and I have talked about ways that you could work toward that, and you're not doing any of that. And he said, well, I want to be happy with her. And so I said, so what you're saying is you want to either be happy with her or you don't want to be happy. He's like, well, that's not exactly what I'm saying. And well, but that's what your behavior is kind of saying. So then we were able to kind of process that out. So if people are saying, you know, I want to feel better and I want to do everything I can to help my mood so that I don't have to be so depressed or so anxious or so traumatized, but I'm not taking my medicine on a regular basis, you know, really help them connect that and explore that a little bit. And then always when we do motivational interviewing, we kind of roll with resistance. So, and you know how I feel about that word resistance, like that's just a hint that we're supposed to be doing something different. if we feel like the client is being resistant, then we need to switch up what we're doing because it's not working. But motivational interviewing can be very helpful when you're dealing with people and trying to help them with medication. I thought since we were talking about medications, it was worth touching base on self-disclosure or disclosure for clients at 12-step meetings because it can be a little difficult at times. So this is the stance from AA about medications and other drugs, which basically says, I don't want to read through the whole things, but it says, the last paragraph, many AAs who have taken over-the-counter non-prescription drugs have discovered the alcoholic's tendency to misuse. Those AAs who have used street drugs ranging from marijuana to heroin have discovered the alcoholic's tendency to become dependent on other drugs. The list goes on and will lengthen as new drugs are developed. Always consult your doctor if you think medication may be helpful or needed. And so AA does not say that medications are not allowed. At least not in the big, I was going to say in the big book, but in the big book or in the big picture, AA does not say that medications are not allowed. Even medications like Suboxone or Vivitrol, it does not say that those are not allowed. However, that's in the big picture. In the smaller picture of 12-step programs and in particular meetings, you may find that that very much is the case. And so we need to kind of educate clients about that. And this is also the AA note to professionals, which basically says the same thing, that they want their AA members to find the right balance and minimize their risk of relapse, and that medication may be a part of that. So AA and NA, all the A's are open to it in the big picture. What we do need to kind of educate our clients about is that they may not be able to be as open in a meeting as they may like to be, or do they need to be? Now, that's the other thing I often tell clients is, I don't usually go to work and say, hi, my name's Jill, these are the medications I'm on. It might come up in conversation with a coworker or something, but it's not, we don't wear a label, like here's my med list on my forehead. And so it is a personal thing that does not always need to be disclosed, including in things like 12-step programs. I think it is always important to be able to disclose those things to your therapist, to your sponsor, to your little we group there in 12-step recovery. And then that gives you more of an ability to talk through. But I think it's important that as professionals, we know that AA and those programs are not against medications in the big picture. And then here's one of my favorites, Carrie Fisher. She says, I'm fine, but I'm bipolar. I'm on 7 medications and I take medications 3 times a day. This constantly puts me in touch with the illness I have. I'm never quite allowed to be free of that for a day. It's like being a diabetic. And I think that's an important thing. I think we look at diabetics sometimes and we are empathetic, like it's like they were like type 1 diabetics. They were just born with that. Like that's not their fault, right? But we look at things like depression, our society anyway, looks at things like depression and anxiety differently. We somehow put that emphasis on the client, that it's a little more their fault. And that's some of the stigma that goes with working with mental illness. So in the chat, let me know at this point if you have any questions, if there's anything that you wanted us to touch base on today that maybe we didn't, or if you have any comments, or if you want to unmute yourself, you can do that as well. Let's see. I'm just running back through the chat to make sure I covered all the questions. Yeah, you guys are kind of quiet today. So it might be the topic. It might be the snow. Might be my voice is becoming too monotone. Okay, so we have a question here to talk a little bit more about Suboxone treatment and how their participation affects their dosage. So thanks for that question. So yeah, let's talk about Suboxone So the threshold, so one of the differences between methadone and Suboxone has to do with the threshold of the dose. So methadone, the more you take, the more impact you have of the medication. And that's why people sometimes, their methadone dose over years gets increased and increased and increased, because there's no like, boom, this is the threshold. With Suboxone, the threshold really is 16 milligrams. Sometimes people take up to 24 milligrams of Suboxone, but what the studies have shown is that once you hit 16, you could take 1 million and you're still going to feel like you took 16, because that's the therapeutic threshold. The medication is not any more effective past 16 than it is lower than 16. So a lot of times the dosage is either 16 or 24, and that's the dose. And then when people, so what they've said about Suboxone is that people really want to look at being stabilized on Suboxone for about a year before they start to think about tapering off. And so after a year, it doesn't mean that they have to taper off in a year, but they can start to, you don't really want to think about it any earlier than a year if you can help it. Once a person feels that they are ready to taper off, and the professionals feel they're ready to taper off, based on things like clean time, compliance, recovery programs, so an actual program of recovery, changes in behaviors, not just taking the Suboxone, but also, taking care of their families, not lying, working, doing the things that they need to do, going to meetings of some sort or having some sort of support, like seeing actual changes in them. Then you can start to talk with them if they may be ready. And this is another area where patients have a choice and a voice. There's a gentleman I work with who, he came to see me after he had been on Suboxone like maybe 6 months. And then after a year that he and I worked together, so he had been on Suboxone for a year and a half, I broached the topic with him. Have you thought about when, what your plan is for in the big picture of Suboxone? And he right away said, well, I don't want to stop taking it yet. I said, that's okay. I'm not pushing you. Let's have the conversation. And so we had some dialogue around that, and we set some time frames of when we were going to check back in on it. So he has a voice too. Like things that I was looking at, and I shared this with him, looked to me like he was getting to be in a position where maybe he may be okay without the medication. But his ideas and his impact on that input in that is just as important. But once you start to see someone who is ready, then we usually taper them off. We don't like people to go off Suboxone, just boom, taper them down, because they can feel some pretty significant withdrawal symptoms. So taper them down little by little. There's a little bit of a phenomenon that people have where they are very afraid sometimes to be off of Suboxone. And I've told the story here before of a young woman that I worked with. She was prescribed, I think she was down to 2 milligrams is what her doctor was prescribing her, 2 milligrams a day. But actually what she was doing was taking like the tiniest little chunk. It was like nothing. And I really don't think she was getting any Suboxone value in her body or her brain from what she was doing at all. But she was reading things online about people who were saying that they were having withdrawal symptoms 3 years after stopping Suboxone. And she just was so anxious and worried about it that she could not get past that. And so we worked on it for a long time. And then what happened is she got pregnant. And when she got pregnant, her doctor bumped her back up to 16 because now, I don't know if he should have or shouldn't have, but he did. That's kind of the protocol. If you have someone who's on Suboxone or using opioids, and you put them on that max dose of Suboxone throughout the pregnancy. And when she gave birth, baby had to stay in the hospital extra because of the Suboxone, but was very healthy. And she detoxed off of Suboxone right after the baby was born, and she hasn't gone back. And it's been, that little girl now is 3. So it's kind of always interesting to me, the things that can impact us and change our behavior. The work she and I did for over a year trying to get her off that tiny little piece of Suboxone was nothing compared to getting pregnant and having a baby and kind of changing her focus on things. So hopefully that kind of answers some of your questions about the Suboxone. The reason that we don't like people to be off of Suboxone less than a year is when they do all those brain scans and then those, those things that show different colors in the brain. When people are using opioids on a regular basis, it takes about a year, at least a year or about a year, for the brain to kind of return back to normal. And so what happens is, because opioids are such a highly addictive substance, telling someone to stop using heroin without giving them some sort of support like Suboxone is almost like telling, like if I said to each of you, I want you to stop breathing for the next 30 minutes, no breathing. Like it's just impossible. And so that's what we found with opioids, is the way those changes occur in the brain, asking people to stop using the opioids without some sort of medical support is almost impossible. And so then we see those failure after failure, which wears people down, which wears our community down, and really we're just not going about it the right way. And so a year, we know in about a year, the brain is kind of returned back. A year without opioids, the brain is kind of healed enough that maybe some people can go without the medication. So I think I rambled on quite a bit there about that. So thank you for that question. I hope that answered that and was helpful there. Any other questions or anything to add?